Thank you so much. As you can see, we're going to go through how some leading health systems are unlocking hospital capacity through care at home. So today we have an all-star panel. They're going to go through the challenges and critical tipping points, maybe some internal operational issues. What were the bottlenecks they're hoping to break? Some of the results and maybe the roadmap into the future. To introduce the panel briefly, I'll start with Dr. Angela Nicholas. She's with Jefferson Health, centered in and around Philadelphia, Pennsylvania, but occupying a much larger region than that. She's the Chief Clinical Officer of the North Region. We also have Dr. Logan Davies. He's with Ochsner Health in Louisiana. He's the Medical Director of Care Transitions and Readmission Efforts. And finally, Dr. Asa Ochsner. She's with Tampa General Hospital, the VP and Associate CMO of Ambulatory Services. Thank you, panel, for joining us. I'm looking forward to the discussion. But briefly, I think let's have them describe where each of their systems are on this road to care in the home. So I'll turn it to Dr. Nicholas first.
So good afternoon, everybody. I am Dr. Angie Nicholas. I am a family physician, and my role at Jefferson is Chief Clinical Officer for a region of 6 hospitals outside of Philadelphia, some in the city of Philadelphia, and then expands and wraps around to about a 40-mile geographic region outside of Philadelphia. We have a large flagship hospital, and like many hospitals in Pennsylvania, we are a bit overrun with patients in our emergency room. In the Philadelphia area, hospitals are closing and reducing services fairly significantly. And in our region, there was one closure recently, and a couple of other hospitals that are challenged with their resources, and we are trying to partner with them to help keep their doors open. As a result of that, we are really protective of our emergency room capacity and recognizing that length of stay really is very challenged. We need to affect our length of stay not in hours, but in days. And so we're looking for opportunities to partner with organizations to do just that, to keep patients out of the hospital that don't need to be in the hospital, but just need services that can't be provided anywhere else. And to do that, we really, we're partnering with organizations to help us do that. The low acuity admissions are very challenging as well. Pennsylvania is challenged with its reimbursement. As the government payers continue to increase, we're getting more pressure from our payment models, and of course, supplies and the cost of just employing our staff, it continues to increase. So we're getting pressures from all sides, and really we think the goal, the opportunity is really in keeping patients out of the hospital or transitioning patients out of the hospital quicker than we've been able to do. We started our pilot at Abington Hospital, which is, as I said, our large flagship hospital in the North Region, in October. The next day started at Einstein, Philadelphia, and as you can see on the timeline, we've been rolling out rather quickly. We are getting aggressive with our rollouts because we don't want to wait. We do see an opportunity. We've taken care of 500 patients now in the patient's home as opposed to keeping them in the hospital, and we're seeing a benefit not only from reducing the admissions, but we're also reducing readmissions as well, and we'll probably talk about a lot of that later. We're meeting all of our key performance indicators that we had planned. The unplanned inpatient utilization, we're very proud of at 2%. We are hoping for 13% coming back and getting admitted into the hospital. And our net promoter score is quite impressive. The DRGs are those that you would expect in the patients with, again, low acuity that we could transition and take care of in the home, and they would be more comfortable, and we could then utilize those beds for patients that have really acute care needs.
Wonderful.
And I think we'll transition to our next speaker. Thank you.
Yeah, thank you. And now we'll go with Dr. Logan Davies, who is at Ochsner Health. Not to be confused. Yes. Not to be confused with Dr. Ochsner. They are unrelated. So Ochsner Health, please, Dr. Davies.
That's right. Hey, everybody. I'm Logan Davies. I'm coming to you from New Orleans, where I'm at the flagship of our 60 hospital system here in the Gulf South. Ochsner, as Clay mentioned, certainly has a most pronounced footprint in Louisiana as the leading healthcare provider in that state, but we also span across locations in Mississippi, Alabama, and even coastal Florida now. We have a very large swath of our enterprise across a great deal of geography. For the exercise and the acute care at home effort that we're talking about today, that's really centered on our flagship region here in New Orleans. We, as I'm sure Angie is accustomed to, and our colleagues over in Tampa, you know, there's always a tip of the spear, and so goes these flagship facilities, goes the rest of the system. We've been very much committed to progress in the space of decanting low acuity hospitalizations from our emergency room and our patient floors for essentially the same tenets and reasons that Angie spoke of. I would add to that is that there's also the expectation in this need for capacity stack redesign that our consumers, our patients, no different than any other industry, want care on their terms in their homes as much as possible, and healthcare certainly needs to be able to match that consumerism expectation. We're very lucky here at Ochsner to be seen as a innovative enterprise. I think we are held in kind of a rare air of a few innovative health systems across the nation. And we see that innovation is really key to our not only our success and our milestones in taking care of patients greatly, but quite frankly, also our survival. You know, I'm not going to get into all the ins and outs of our finance makeup, our patient mix, our patient kind of frailty scores. They're not great. But despite that, we achieve good outcomes, and what we've been doing in our space of acute care at home, I think really speaks to our penchant for innovation, despite some of the things that are stacked against us to do great things. Yeah, I'm excited to talk to you all a little bit more about like what we've done over the next hour, but here's just a snapshot of what we've done. We're a year or two ahead of where Angie is in Jefferson in the Philadelphia area. We're now approaching almost 3,000 episodes of care in the patient's home settings. And several of those KPIs match directly to what she was saying. We have very, very high net promoter scores with our patients and referring providers alike. We have a significant reduction in recidivism to the hospital, whether that's emergency departments or that all-important inpatient readmission measure. We've seen that come down in excess of 50%. We've seen several $1 million in organizational savings attributed to this, and we're actually seeing in our value-based population a significant reduction in total cost of care per episode of care. And as you would imagine, that has a trickle-down effect to our patients who are also experiencing about a 30 to 40% reduction in out-of-pocket costs. We have a few different products that are in play right now, and a vision to do even more. And like I mentioned, we'll have some time to talk about not only what we've done, but where we're going in the future. And Clay, I'll turn it back to you to do our final introduction.
Thank you, Logan. Dr. Asa Ochsner with Tampa General.
Thanks, everybody. So, you know, here's Tampa General and USF by the numbers, so you can see we are, you know, we're big. We have an academic medical center as well, and then some community hospitals in our network, and then a large outpatient network as well. And so it's very similar setup and concerns that our system has as what we've heard so far from Jefferson and Ochsner, where the inpatient capacity is, you know, completely spent. People are in the hallways getting inpatient care in the hallways. And our team was really charged with, okay, if you can get inpatient care in a hallway, then can't we figure out how to get inpatient care in a home, or OBS care in the home, or discharge this patient and still get them quickly the wraparound care that they would need to get in the home. And so really that's why we designed, our multi-level of care at home, like we've been hearing about. And I think a lot of what we have is very similar to Jefferson and Ochsner. We've got the pre-emergency room strategies to try to keep patients from ever going to the emergency room, try to avoid utilization in the first place, try to do care coordination for them ahead of them even arriving there. And then we have, once you're in the emergency room, we have diversion opportunities so that you can be discharged instead of admitted. Once you're admitted, we're on you all the time to try to get that length of stay as short as possible and as safe to transfer you into our ambulatory system to continue getting that care. And then we've got post-discharge programs to reduce your readmissions, like Dr. Davies was really talking about. So I think it's going to be great discussion with the panelists to hear how we're all going towards the same things, but in slightly different ways, and how we've all gone after it.
Great, thank you. Lastly, I'll give a brief overview of My Laurel Health. My Laurel is a mobile medical group that helps hospitals and health plans care for complex patients safely at home. So we do this with a very high touch, in-home model. And really we are operating in a couple of lanes. On the front end, pre-hospitalization, we can see patients even before they ever go to the ED, or as you'll hear about, we can capture them in the ED and divert away from that OB stay. On the post-hospital side, we can help reduce length of stay by taking patients a day or two or even 3 earlier, or take your very high-risk patients that may come back frequently and care for them in the home, greatly increasing their chance of success transitioning to their ambulatory care team. We do this with our mobile medical group. You can see we have in-hospital liaisons to introduce the service, field responders and virtual physicians, nurse case managers, and we are available to our patients 24/7, 365, on call for 12 of those hours and able to deploy for 12 of those hours. So that's a brief overview of My Laurel Health. And we'll jump right into the questions now. So first, we'll start with kind of the challenges and critical tipping points. And I think we've heard some of this, but let's put a little bit finer point on it. As each of you was looking to launching into care in the home, kind of what was the driver? What were you seeing specific tipping points in your system where you realize, my gosh, we can't just build 7 more hospitals to take care of this? And we'll start with Dr. Davies.
Yeah, so a few years ago now, I believe it was 2024, was our health system's operational and financial nadir. Anyone who has, heard me present or heard the story before will know that that was not only a time where we were out of step with our high-performing tightness of our organization, but it was also a sad time for us because it's the first time that we ever had a reduction in force in our operational history. And so we came to work one day and many of our colleagues were being escorted out. Why that's important is while the clouds were dark and times were unsure, it was also a time in which we really rallied ourselves and tried to figure out what we needed to do to rectify the situation. And as Angie mentioned in many of her remarks, I mean, our reality is like hers. It is, we had patients stretching down the walls of emergency departments. At a high acuity referral center for a 3-state region, we had a significant number of patients with low acuity diagnoses. So they were displacing patients who needed to have the care that only this facility could provide. We had growing length of stays. We had readmission rates, just off the charts, and by some consortium's measures within the bottom 5. So we were, again, very out of step. As I mentioned, we're a very innovative organization, and these numbers did not match the prowess that we were used to. And our patients and our Ochsner family was suffering as a outcome of all of this. So we decided that we needed to upend the way that we're caring for our patients. We had an organizational history with hospital at home. We had a foray into that in the mid-2010s. And for us, it was something that we could not find our footing with and a return on investment with the CMS parameters. But we understood that there was a lot of good there. And so we were seeking a partner that would allow us the latitude to provision care for patients, get them out of the hospital and into their homes, which is a win for our patients, but also a win for our facilities. And to do it in a way that was a little bit more of an open book, that we could kind of self-author our journey in the way that our patients would be taken care of. Because at the end of the day, I think our organization is not unlike all organizations. We take great pride in how our patients are going to be cared for. And I think we would all say that we know how to take care of our patients the best. And with that, we were able to find a partner with MyLaurel and to co-develop the set of services that are now known as acute care at home. We started first in our value-based population and took care of the patients who were low acuity. They were safe and appropriate to be cared for elsewhere, and it also aligned with their goal. We were able to move the needle there, and then we turned our focus to our readmission opportunity, which was a big one, and have made significant inroads to all of that. So just to kind of put a cap on all this, it's the common things that were hurting us. It was too little space, too much business, but kind of the wrong mix of business. We had too much repeat business, and some of that repeat business we did not need, and it's not patient-centered in the way that we were rendering care. And so we sought out to have a model to help us to rectify those things. And if we take care of our patients first and we get good outcomes as a consequence of that, we also saw that this paid dividends in other ways, and especially the financial piece where we were able to make sure that we got a return on investment for the investment that we put into this novel care model. So yeah, that's kind of where we started. It's still very much an evolution right now. And I'm sure we'll be talking about things as they have evolved and as we are continuing to learn and collaborate in this space with MyLaurel.
Thanks, Dr. Davies. Dr. Ochsner, what kind of challenges and tipping points were hitting Tampa General before you really started looking into care in the home?
So similar, I think our capacity was the main challenge that we were trying to solve. We want to grow the service line business, but we have nowhere to put people if we grow it, right? So we're sending all the service lines out, market, growth, advertising, all that good stuff. But then they turn around and they're like, where do you expect us to do these cases? Where should we put people? So if we wanted to do that, we would have to fix our capacity and our challenges. And we really need to do that because, we're in a very competitive market. We have, met other really massive healthcare systems here. And so we can't just stay left behind, right? So that was one for sure. And then another challenge that we had is also our readmission rate. As the same as Dr. Davies was saying, we have a high readmission rate, and it's not necessarily the patients that we're able to do more for, right? We have tried to help those patients, but really what we need to do is to enable their home environment to be a healing environment for them, and that is what would help the patients actually get better. And so we weren't attacking it from that direction before. But now when you do a visit in the home, you can really dig in and understand everything that's contributing to that patient's health or lack of health. You can see their refrigerator. You can see what their living situation is. You see their who's around, who's living with them, and all of a sudden you start taking care of the patient in a different way.
And you can see, I know my team has heard me say it frequently, you can see 42 other pill bottles that were supposed to have been discontinued, and it's very confusing to patients. So I get it. And when you say capacity, are you saying ED capacity, inpatient capacity, surgical capacity? What are you thinking there?
Yeah, so for us, it's inpatient capacity and surgical capacity, because both of those are full. You know, we already started second shift surgery, so our surgeons operate till about 11 p.m. They do first shift, and then a whole nother team of everybody, including the surgeon, is another surgeon who comes on and does second shift surgeries. Then obviously we do emergencies overnight, but you know, at planned surgeries we do 2 shifts. So we're over capacity on both of those.
You're busting at the seams. Okay. Dr. Nicholas, I expect similar things from you, but what would you add to some of those issues? I know with hospitals closing around you, that just further stresses the whole system, right?
For sure. And I think, you know, for us, we live in a partial value-based world with our insurance product. And as we were, and our ACOs that we're engaged in, and as we were looking at the cost of care, our cost of care was increasing as well. And so, and we had a bit of the perfect storm. I am involved in a length of stay. I think we've all been involved in length of stay initiatives from the time we graduated from medical school at this point, but intimately involved in the length of stay initiatives that we have at Jefferson Health. And in addition, I became the interim CMO at our flagship Abington for a bit of time, and recognized that we had a bit of a perfect storm happening. We had, you know, these increasing volumes in the hospital and the ED. We had the hospitalist program that really needed a bit of a reboot and redesign. And so, and this all kind of came together at the same time. We started looking at our value-based patient care and recognizing that a population over the age of 65 coming to the hospital costing a lot of money, and we weren't discharging them in a timely fashion. So it was all kind of, you know, piling up. From our hospitalist perspective, as we talked with them about the redesign, I'll say the first meeting was a little tense, but after the meeting, as they recognized, you know, hey, maybe this isn't going to all be bad, you know, their answer to me, or their question to me, was, what are we going to do about the patients that come into the hospital that don't need to be there? And the good news was I had an answer for them, and said, in November, we have a program. And we were actually able to pull that in and actually implement it in October, which was even better news for them. So they were really engaged in the work that we were doing to redesign their process, because we had another option for them to get patients out of the hospital quickly and out of the emergency room quickly. And as I said before, you know, our value-based care costs were increasing, and that is another lever that we had to be able to get those patients to the home. And interesting, I'll tell a little story. Our first patient was a 90-year-old patient with abdominal pain, had been in the hospital a couple of weeks to maybe a month before with a very large workup with no obvious cause. So the patient comes back to the emergency room and everybody thinks, oh gosh, here we go again. We were actually able to discharge that patient home, bring resources into the house. And honestly, this was not a medical issue. This was a psychosocial loneliness issue. So we were able to use our health-related social needs data to really be able to connect with that patient and really help them and stay in his home and really affect his care differently. So that story, once everybody heard it, and we made sure that story went around really quickly, that story really made people realize we really could make a difference with our patient care, which ultimately is really the most important thing that we're doing here.
Wonderful. Yeah, I agree. I think buy-in can be partial through metrics and data, but when we start to see those patient stories and improved outcomes and people are happy getting care in their home, that's when it really starts to affect the care providers in the hospital, and they say, yeah, this makes a lot of sense. Let's get going here. It sounds like it's safe to say that this is not just kind of an interesting pilot of care, but maybe an operational necessity for each of you to have some form of care in the home. Is that safe to say? Okay, great.
Without a doubt.
Yeah, let's move. I think we could talk about the challenges all day. I would imagine many in our audience are familiar with them because they are living them as well. But you've identified the challenges. You say, okay, we can do this care in the home, help our capacity, decrease the readmissions, but then we got to make this real. And that's a challenge. So what are some of the operational bottlenecks in terms of launching this? And let's just stick with a winner here and go with Dr. Nicholas, since she's on deck.
Well, I think, we had a lot of acceptance, I think, pretty quickly. Emergency department was engaged. Pennsylvania is also a high liability state as well. And so I think there's a lot of concern around the liability associated with sending patients home that we haven't sent home before. We really had to get over that hump. And, I remind our physicians that we're all liable for the care that we provide. And shouldn't we provide the very best care? And, whatever happens, happens. But if we provide excellent care, that's going to be the most important thing. So I think getting over the hump of doing something different. And we tend to weaponize a little bit liability, but really, it's doing something different. We all tend to, how do we identify the patients? Who's identifying the patients? And working through that with the team. There's always, a lag a bit. We want to do things faster than our IT staff has the capacity to be able to do things. They can't do things in a flash. And so that was a staged approach about being able to identify the appropriate patients, because we really went with a list of patient demographics and that we wanted to start with first to really see what we thought was going to be the biggest bang for our buck. And then I think overall, again, it's change. It's doing something different. It's different workflows. It's, it wasn't available today. Is it going to be available tomorrow? And reminding everybody the timeframes and, again, all of the things that go along with implementing a new program. Since we did our first launch, we learned a couple things, but I think we've been, relatively seamless, and we know how to answer the questions a little bit faster. We can answer them ahead of time now. So I really think it's a matter of how fast can you roll it out, and what are the different use cases that you can have. Can we call from the ambulatory office? I think we're starting to think about what are the other things we could do. Could we call from the ambulatory office and we have a patient that maybe should go to the emergency room, but maybe not. And maybe if we had somebody that could go see them tomorrow, we wouldn't have to send them to the emergency room. Again, there's lots of use cases for that, and how do you operationalize all of those? So I think, the initial hurdles are the typical hurdles that you see in every project, but nothing out of the ordinary from our perspective.
Sure. Thank you. And Dr. Ochsner, when you seem to have a philosophy around it. Think ambulatory first. How do you get people to buy into that? What were the bottlenecks that you saw at Tampa General?
Yeah, so for us, what we did is we used our data and we looked at the top 10 DRGs that were contributing to excess days and to excess readmissions. And they were the same 10 DRGs, basically. Things that you guys would all expect: heart failure, COPD, UTIs, pneumonia, same old, right? And so we were like, great, this is great, because it's bread and butter. We know what we can do. We know how we can do it, right? And so that's what we did. And do we have anything? Do we need to redeploy or move something around? Are there any gaps that we actually don't have that we need to build an infrastructure for? And it took a little while, honestly, less than a year, to get all of those top 10 with really slick pathways that were the easy button. And our ER docs now say that TAF, or Think Inventory First, they call it TAF. They use it kind of like a like I'm taffing this patient, but they say that that's like the first thing in over a decade that the health system has done that actually makes their job easier, instead of all the other stuff that we've tried to do to stop a readmission or to increase, the throughput. That has really actually made their lives harder. This is one of the first things that's made it easier, because we just made it an easy button. And so I think that I think it's really important, when you are going to go operationalize something, use the data so that you can say why it's important, and you can follow that up, and you can say, we went from here to there. And also design it in a way that's going to be easier for the front line. If it's easy, then they're going to do it, and that will take away that bottleneck. And then over time, you see the adoption really take that slope very quickly, because you've made it easy for them.
Wonderful. I love it. Dr. Davies, you've got an executive view of this, and you've been in the trenches on some of the bottlenecks, from EHR to case management to floor staff. How do you think about some of these bottlenecks that you've run into?
Yeah, well, I think what we've just heard from the other two contributors is right in the vein of things that we were thoughtful to tackle too at the outset of this, just from attitudes and perspectives, as we heard a little bit earlier, is really depowering the myth of liability, and meeting that with having your legal folks in there, whoever your partner is, or whether you're doing this under your own shingle, like really understanding and being able to articulate that to the providers. It's almost always the first thing that they will throw out there. And I think if you can hit that nail on the head really quickly, and with a concerted, very concise answer, you get quickly past that. The other thing that we just heard that certainly rings a bell is this can't be an alternative to a hospital path, cannot be harder than a hospital path. And so much of the literal process design and the engineering is incredibly important to driving your outcomes. I spent most of my time in the first 6 months of this with our IS and process team, and I was tyrannical about this. It can't be over there. It has to be in existing workflows. It has to emulate existing workflows. And again, that is part of what we heard from our end users is, once we got away from the concerns of, is this safe? Am I liable? Then it is literally, is this going to be as easy as, because I'm busy, I don't have time. So certainly the on-ramp has got to be intuitive. It's got to be efficient. It's probably got to be even more efficient if you want to have that adoption than the normal routes. And then similarly, I think getting in there and seeing these patients, especially if you're triaging, assessing them and getting them out of the ER, that has to be quick or quicker than the status quo. And I think the other special sauces in there is, however you do this, whoever you do it with, is getting folks in there as a member of that team, working with them, developing those relationships. People do the right thing a lot more easily when they're doing it for someone. So when there's that social contract between team members, it's so obvious, but it's often overlooked. I would tell you the one thing that we learned early on, and I'm glad that we got there earlier than later. We had our finance people on the ground floor of this, constantly iterating this work. As this is, at least with our partnership, we did do value-based care, as I mentioned. We did a financial analysis and actually expanded this to all senior payers. So this is what we call a Medicare agnostic service. But we did a lot of financial diligence to keep our CFOs literally on side of this and supportive of this, because what we wanted to nullify was the idea that this was costing us something, because it just kept coming up. And we really had to, with their insights and their expertise, come up with truly a winning formula that we could define ROI with not any special tricks or levers or anything like that, that this would work and would be something that would, not bleed red ink all over their spreadsheets that they're seeing. Our CFOs are necessary. They help us to keep the lights on and, keep the little gears greased that help us to take care of our patients and our team members alike. But they are removed from patient care, and their skin in the game is completely different. And so it is really important that with clinical partners like us, is that where there's that tendency to kind of bang your heads against one another, is to actually come together, figure out that common ground, and then just find the formula and work it from there. So I think if I were to give anybody advice beyond what we heard from our other contributors, is getting that finance person in as a champion on the ground level, and it will pay dividends.
Excellent. I have a follow-up question for you, Dr. Davies, but what I heard, if I summarize the three of you, it's got to be good care. It's got to benefit the patient, or it's a non-starter for providers, for systems alike. It's got to integrate. So you need good integration with existing workflows and systems, or it's going to be dead in the water because nobody will use it. Then it becomes the easy button, which is what we really want. That's when it spreads like wildfire throughout the system, because who doesn't want an easy button in healthcare today? And then lastly, Dr. Davies, you mentioned financial alignment. So there's got to be an ROI. And it's a new philosophy. If you go and tell someone, I'm going to take everybody out of your hospital, they're going to say, I'm sorry, that's not really compatible with us surviving. So it definitely has to align with the financial expertise of the CFO. And since you mentioned some of that, Dr. Davies, how did you evaluate partnering versus building this on your own in today's labor market with hospital competing priorities?
Yes. Very good questions. So, a little bit of the story is I had set parameters that were given to me by leadership. And when we set sail on this new foray into the care nearest the patient in their home space, it was, we're not going to start with hospital at home. Again, organizationally, historically, that was not something that generated an ROI. And the concept at that time was a little bit of a spoiled idea. So we needed to do something different, but also maintain what was clearly of value. I mean, everybody gets it. It is the utmost idea of patient-centeredness to be able to take patients as good as we want our hospitals to be. They're incredibly chaotic and miserable. It just is what it is, folks. And so we knew that there was a there in taking care of patients in a different way. We started this. There was a request for proposals. We got several back. And for what our organizational kind of steady state is that we needed something that would be an extension of our brand, that would be a seamless kind of continuation of Ochsner. That was one of the core philosophies of what we wanted to do. We also needed something. We were a greenfield in this space of development. But with our penchant for innovation, we also wanted somebody to be able to develop things that were bespoke and sensitive to our operational needs and ethos here. And so we looked at some other vendors who had operated more at mass, at scale, but they were very hard and fast that this is our product, this is our labeling, this is, the way we're going to execute it, and you're going to pay a very high dollar for that. Then we also had to consider what is market readiness in terms of these folks coming in. So it's a little bit of a mix of things in terms of, certainly it is the dollar cost. Then it is the right partner in terms of, how that's going to represent and carry your brand quite literally into the patient's home. Then it gets into the malleability of the products. Some folks maybe want a turnkey solution from stem to stern. We wanted to be able to kind of co-author that journey a little bit more heavy-handedly, or if that we wanted to pivot out and do something else that we could co-pilot that with our operational partner at MyLaurel. And then, ultimately it was also who was in place with the care delivery and logistics partners in our markets to be able to do things on a time horizon that met our needs. And ultimately, when we kind of looked at those three things, it aligned, to our partners with MyLaurel.
Wonderful. Thank you. Again, I could sit here for a long time with this group of questions, but with an eye on time, let's go ahead and move on to some of the results. And I'll start with Dr. Ochsner. What are the most surprising or shocking or unanticipated results you've seen with care in the home?
The most surprising results that we have seen is our bed days saved. So as Dr. Davies was saying, you have to talk with your CFO about how they're going to give you return on investment for a project like this. And so for our CFO, the return on investment that they measure is bed days saved, and they have a calculation of turning that into dollars, of how much dollars they can generate by backfilling that bed. Now, if we ever get to a point where we can't backfill the beds, I'm sure that calculation will change for our CFO. But for now, we're not in that space, right? So for us, it's our bed days saved. Since our program started all in, we're well over 20,000 bed days saved at this point, since 2023 when we started. This fiscal year, we're in the 5,000s so far this fiscal year, and we've got some quarters to go still. So the numbers are just amazing, and you really think about for centers that are at capacity like us, you really think about how much that means to the system, to the care teams, that those patients got what they needed, and that they have been able to continue doing their work with the easy button. So it's really staggering. The other our other KPIs for sure are the readmission rate. So our readmission rate, revisit, both ED and readmission combined, revisit rate is less than 5% for patients that come to us, which is fantastic compared to the patients that don't in our healthcare system. Some of our Vizient metrics around care coordination and 7-day hospital follow-up are getting way better. So those have been some really nice stats to show everybody. And we tell folks that some of the referring docs are going to be convinced because of facts and data, and some of them are going to be convinced with stories, like the one that we heard from Dr. Nicholas. And so every time we present, we try to have both, so that we can kind of, whichever way their brain processes this stuff, we can catch them one way or the other.
Wonderful. Dr. Nicholas, what about your results? Anything shocking or surprising, or maybe the standout stat?
I don't think anything shocking or surprising, but the one thing that I do want to address is clinician well-being. And, I think our physicians get distressed when they take care of patients in the hospital that don't need to be in the hospital. And they feel like I'm taking care, like they're happy to take care of the patient, but if we could just do X, we could send that patient home and we could get them back into the community. And as I talked a little earlier around the hospitalist program, I think they're starting to feel like they have a bit more say in, in or out, the patient stay or can the patient go, and how do we transition that patient in a way that gives them the services they need without needing to be in the hospital. And so one of the things that we're measuring for our hospitalists as part of that redesign is clinician well-being, because I do think that that's an important part of what happens. Sometimes physicians feel like they don't have a choice but to bring a patient in, and now we have choices and we have options, and that's having options is one of the things that we found is a key to enjoying the work that you do every day, when you have choices and things that think about it and I could do this or I can do that, as opposed to I'm backed up against the wall. I think, our decreasing cost of care is going to be something to track. And as we move along into our larger health systems, our larger hospitals, that's going to be, factor by X. So decreasing the cost of care in our value-based programs is going to be really important, and making sure that we're continuing to address that. And obviously, as we address with all of this, we're addressing the CMI and raising our CMI and allowing us to have, more patients in the hospital that have more complexity of the care that we're providing. That's really important to us. I think, we saw our metrics earlier, and I'm still a bit, it's early on, but I'm very, very optimistic about what we're going to see over the next, 3 to 4 months, is more hospitals and more patients, and more metrics associated with this.
Wonderful. And Dr. Davies, we've been at it a while. What do you think of your results? Are there any standout results, either value-based care or fee-for-service, or shocking or surprising downstream impacts of the program?
Yeah, we all have triangulated on the same KPIs. There's access, there's financial, there's these outcomes in terms of patient satisfaction, quality, and safety. The evidence is robust, and our examples are no different. That when you do these home-based solutions, it mints outcomes. Because I think at the core of it, it may be an oversimplification, but I do believe it's true, is that it's the right thing to do. And it gets back to that tenet of, the right thing at the right time for the right patient. And when you put a tool in that space, you're going to get all these good things. So like my colleagues here, when you just go down the waterfall or the table of all the KPIs, these things that were really red in the worst ways are either emerald green, or they have such a significant delta of progress that the results are undeniable. What I would tell you, and I don't want to kind of retread the same ground as my colleagues, of what has been the unintentional or kind of the surprising pickup of all of this. Kind of a key theme you keep hearing me talk about. We're very proud of our innovative kind of streak as an organization. But in this space of transitional home care, we have really not been kind of at the front of the curve. And we have some network in-system solutions that exist and have existed. And there has been some healthy tension, maybe even some friction with these programs as we started to be really successful with this particular program. And that friction soon moved to a place of, now all of a sudden, it's undeniable, these results. And they start to wonder, well, what can we do to produce those levels of results? And there's always maybe a little bit of kind of copying good work, if you will. But even that starts to needle to the right place, where things, instead of trying to be in competition with one another, what we're really starting to arrive at the place of, how do we complement one another? So how can we take these winning things that are right for our patient, right for our institution, mint the outcomes, but then also help us to maybe reconfigure the service offerings that exist in complement around other things. So we kind of think about that ecosystem of care, that we're not essentially duplicating services, that we are not duplicating dollar spend. So that has been a really surprising thing. Again, it's kind of taken this arc from some competition and some kind of internal frustrations, and now it's really settling out where that competitiveness has helped to kind of, this rising tide is lifting all boats. And it really has lit a fire for us to really think about the continuum of care. I believe that without this example, we would probably be 2 years behind ourselves right now. It really has lit the afterburners for our organization, not only for this application, but other things, both that is under our shingle and things we contract with.
Excellent. Okay. One more question for the panel. But I did want to let all of our audience know we'll have a little bit of time for Q&A at the end, so please feel free to put questions in the chat. It's rare to get access to these three big brains with experience and knowledge, so use them while you got them. The last question, kind of a two-parter, is going to be one piece of advice you'd offer to a system that is considering a model like this, and then looking back a year from now, where do you hope you'll be, or what's next in your care at home journey? So advice and what's upcoming, where do you hope to be? So for that, we'll start with Dr. Ochsner.
Yeah, it's a great question. I think in terms of advice, I would have the advice of having a really big tent. I think it's been mentioned a couple times for different reasons, right? One is you'll get more adoption if people are part of being able to build the solution that they're going to use, right? Two, think of people that you don't even normally think of, like finance or whatever, right? Operations, you might have to talk to your access center because all of a sudden you're keeping people in network and they actually come to the appointments that I've always been recommending them to go to. So have a really big tent is my biggest piece of advice, and get them on early and keep them updated. Even if they don't, you can say, hey, you don't have to come to every meeting. I'll let you know if there's something that I really need you on, but at least check the emails or pop in for 10 minutes here and there. Stay connected to the work so you know a little bit about what's going on, you know. And then looking forward in a year, we are, I think our most impactful part of our team is our PharmDs, who do a ton of excellent medication therapy management. And so what we're doing looking forward over the next year is we're going to actually recruit a lot more of them. And we are looking to expand the pathways that they are going to be assisting on, especially with our remote patient monitoring. So we're going to do more remote patient monitoring, partnering with PharmDs that will receive the results and titrate the patient's meds to get them hopefully, you know, really, really optimized within that 30-day transitional window after discharge. That's our next year's book of work.
Excellent. Okay. Dr. Nicholas.
So I think advice would be engage the primary care doctors. We thought we did a good job of making sure that primary care doctors understood the model and what was going to happen to the patients. But you know, you can't over communicate. And I think even though we communicated multiple different ways, I think they just, oh, it doesn't matter to me. It has nothing to do with me. And it actually did, because it was their patient getting care from what they perceived as an outside provider, and didn't understand the connection. And so I think, and they're very supportive once they hear. I'm really quick to pick up the phone and make a phone call if there's a question or a concern and really talk about the program. So that was one area of lesson learned. I think we are moving quickly, and I think it can be done quickly. And I think that's another lesson learned. You don't need to wait 6 months to the next hospital. I mean, we did days, you know, a day, 2 days. And I think if you have the, you know, I think you can do this with obviously multiple staffing people, you know, staffing in the emergency room. I would love to be able to get to a way to do this a little bit less, you know, maybe a little, I don't want to say remotely, but maybe regionalized a bit so that we don't have to have so many people all the time. But there may be some ways we just haven't thought about, and we're still young in it. In a year, I'd love to have my length of stay down by a day, and really attribute that to all of the good work that we've done in multiple fronts. So this is a tool in the toolbox. This is not the end game, but really just a tool in the toolbox in many ways to approach a really complicated situation in a very complicated system that we have. So looking forward to seeing what other things we can come up with in the next year.
Excellent. And Dr. Davies, you want to close us out with the same question?
Yeah, so my advice, the first one's going to be really just practical advice. Just start somewhere. I've now had the opportunity to consult a lot of large health systems across the nation in this space. And, hindsight's always 20/20. So I have that, privy perspective. But just to see all the consternation and kind of the hand wringing that people are going through, and it really stymies progress. And look, like many large health systems have the benefit of having usually some degree or a large degree, a concentration of value-based care. That is a really safe harbor, unless things materially change, to launch and pilot these things and show directionality. And our math, generally all math's the same way. As I mentioned earlier, we have moved to a senior agnostic position with a lot of our programs because, quite frankly, just on the balance sheet, a lot of that care is loss leading and significantly so. So, there is plenty of opportunity where this whole cost thing is actually for not only the betterment of the patient, which is obvious, but as I mentioned, got to have that betterment on the balance sheet as well. In terms of a little bit more of a technical thing, integration, when you really are thinking about having a vendor partner come in, look, as hospital systems, we're by and large almost, it is an epic game. And that is not the reality of a lot of in-home vendor partners. And so I would encourage you also on the ground floor to have your IS folks and particularly folks with an eye towards integration in on those discussions. And that does not mean that that is at all a day zero, day one requirement, but it is something that needs to be on the horizon and that you are working incrementally to. So meaning that whatever your gap solutions build to whatever the most ideal integration is. And there are solutions out there to bring things within Epic. You just need to have those conversations. And then finally, I would say none of this is a one size fits all type of kind of proposition. I started this whole discussion with saying we did not want to do waiver-based services because of our history. We are now at a point saying that we actually believe the continuum of care looks best with having waiver-free solutions like MyLaurel, and also exploring waivered solutions like traditional hospital at home. And I think that when you kind of look at the menu of options, you've got to be really open to having a full slate, and that includes not only near patient in-home solutions, that includes virtualized care, that includes self-service options. But we have a tendency to almost run towards one thing at any one time. I can't tell you how many times I have to hear about virtualizing the patient population writ large. And I'm like, what's the fluency, the digital fluency of our patients to be able to take that on? So there's just so many different nuances that you have to consider as you build the menu of options. And it's what it has to be. It has to be a menu of options. And then 1 year. I am very bullish on using these type of services and continuing to build on them. And where I want to build on them is get them to the patient sooner, that they don't have to come to our big, busy, chaotic brick and mortar locations. And so how do we use the leverage that of having a waiver-free service to pivot out of maybe a virtual visit and deploy a resource to a patient in need in their home? Or how can we actually maybe even go to clinics and meet patients there and then take them home? So that's where I'm kind of thinking the future lies. We love the technical skill of the paramedics and the provider partnerships that the MyLaurel example provides us. So how do we actually get them in the sweet spot of doing that sooner than having to come into our hospital settings?
Wonderful. Thank you all. I think there's great advice mixed in there, and look forward to seeing where everybody is at in a year. Unfortunately, I plugged the questions. We got some great ones, And I don't think that we have time to answer any of those questions. Fortunately, we will follow up with each of you afterwards to give you the answers to those questions. There is a brief 2-minute survey following this webinar if you wouldn't mind filling it out. And then feel free to reach out to MyLaurel, of course, sales@mylaurelhealth.com, or just look us up on the internet, mylaurelhealth.com. And I think with that, I will turn it back to Beckers and Randy.
Thanks, Dr. Watson. Thanks, Dr. Nicholas, Dr. Davies, and Dr. Ochsner for the excellent presentation today, as well as MyLaurel for sponsoring today's webinar. And thank you to our audience for joining us as well. We hope you have a wonderful rest of your day.